Okay, Ali.
Bismillah ar-Rahman ar-Rahim. Good evening, everybody. I'm Dr. Ali Mohsen, Medical Manager of Asino, and I'd like to welcome you to the second session of our webinar, Practical Pediatric Orthopedic Problems, organized by the Iraqi Orthopedic Association. Today, we have 5 interesting presentations, so allow me to start with our first speaker, Dr. David Spiegel, and his presentation is titled Tips and Tricks in Management of Lower Limb CP. Dr. David, please, you can proceed.
Thanks so much for the opportunity. Sorry that I'm not able to be with you in person, and I'd also say thanks to the other faculty members and
Most welcome, Doctor.
To the organizers for including me. And it's been a pleasure to know Dr. Hamdan for 15 years and Dr. Mubdar and Ali and so many other good friends who I wish we could all be together, Dalal, Scott, and so on. So I'll try to do my best in a short period of time to just share with you some tips and tricks in the management of CP in the lower limb. So this will be mainly about ambulatory patients. So when we're charged with evaluating patients with this diagnosis, part of our challenge is to identify in our minds what are the neurologic impairments and what are the musculoskeletal impairments and which are most important in trying to improve this patient's condition. Understanding the GMFCS level is of critical importance, as we'd expect 1s and 2s to pretty much stay on a plateau into adulthood, whereas the GMFCS3 patients are the patients who are most likely to lose function during adolescent years and end up requiring more of our attention. In the younger children, it's quite clear that gross motor function improves until the kids are in the range of 7 to 9 years of age. So anything we can do to avoid orthopedic interventions to that point is helpful. And then the issues, the musculoskeletal issues, as we all know, tend to progress. So a nice way to think about it, each individual patient, is that they have neurologic impairments and they have musculoskeletal impairments. As orthopedists, we're most familiar with muscle contractures and the skeletal deformities. But when we're looking at the primary or neurologic impairments, we're interested in seeing, well, does this patient have excess tone? And if they do have excess tone, is it pure spasticity, or is there a component of fluctuating excess tone called dystonia? Do they have extra movements, hyperkinetic movements? Because too much tone and too much extra movements will certainly impact their positioning, ease of care, and ambulatory ability, and will impact on the orthopedic treatment. Those are the so-called positive neurologic signs. Negative signs are also of critical importance. We tend to focus so much on spasticity when in fact underlying muscle weakness may be more of a problem than spasticity when it comes to overall function. The ability to control movement, selective motor control, to isolate the movement of a single muscle unit is very often impaired, and then impairments in balance. So all of these neurologic issues will persist, and families need to understand exactly what can be achieved with addressing the musculoskeletal components of this patient's problem. So we can't fix the brain by operating on the legs, although our goal is to try and maximize or improve the ability or maximize the biomechanical potential of the musculoskeletal system. So in ambulators, there are a lot of different things we can try to help. Maybe something as simple as trying to help a patient to walk a longer distance to improve their function. Some patients, particularly those who walk with a flex knee gait, will have pain in the knee. So we're trying to help with knee pain. And then there are other patients that seemingly walk so well that we may actually only be improving the cosmetic aspects of their gait rather than functional aspects. But I think according to the World Health Organization ICF format, what our goal should truly be is to improve participation and a patient's activities. So then we select the orthopedic interventions and their dose, meaning to what degree do we need to correct. We prescribe orthoses, which are still important after orthopedic surgery, and then the extensive rehabilitation that's required. So all of us, this is a nice article, but we all tend to be systematic, first talking to patients and their families and understanding exactly what their functional deficits are, what they hope to achieve with active treatment. Then the physical examination is critical to get some estimation as to the soft tissue problems and the skeletal problems and their magnitude. Diagnostic testing, often we get X-rays, for example, standing radiographs of the foot and ankle, and pelvic X-rays. Quantitative and gait analysis is popular in many areas of our country, but certainly I would say that at the global level, simply the ability to have slow motion video through a handheld camera or an iPhone can be sufficient to give us a pretty good assessment of the specifics of that patient's gait. And then finally, the exam under anesthesia when spasticity has been eliminated under general anesthesia to get us a final assessment of the true range of motion at a joint. So what are the tips with the surgical treatment? Well, one is to recognize that there are bone problems, there are soft tissue problems, and that they occur at multiple levels: hips, knees, and ankles. And so the key is to be able to define all those elements that are impacting the patient's ambulation and then to address them all at once in a single setting. So therefore, once again, determining which procedures and which dose of the procedures. Conceptually, I think I would advocate for trying to restore skeletal levers and trying to be quite limited in our soft tissue lengthening, as that weakens muscles that are often already weak. And then patients will always have to continue to use orthoses in the majority of cases and their assisted devices. Rehab, maximum benefit after these lower extremity procedures can be a year later. So families have to be counseled appropriately. The challenges that I've had over the years, I guess, one, we have to think about the individual patient. Some of the children will also have behavioral problems and issues that make it difficult for them to participate in rehabilitation, and we have to take note of that. Some patients may not be that motivated and may not want to get better. And in our setup, particularly in teenage years, many of the patients, now maybe it's just in my community, big city community, but many of the patients are overweight, which is a big problem with underlying weakness. And then failure to appreciate substantial underlying weakness, and also the importance of failing to recognize dyskinetic involvement can all have an impact on the results of the surgery. Then there are the issues related to the family and the social circumstances, who's looking after the child at home, what's happening with schooling, is rehabilitation available, and that type of thing. Because even the best surgery can turn out to be a failure if adequate rehabilitation isn't provided. And so this is a community by community thing. And I would say even in a big city within an economically developed country like ours, there are lots of gaps and lots of holes in children's access to rehabilitation. So just to go through some of the, a few of the specific areas: the hip, the main problems are flexion, contracture, and in-toeing or scissoring gait with the femur crossing over the other knee. The problems relating to this can be soft tissue or bony. With regard to the in-toeing, the classic is to evaluate which component is bony and which component is dynamic. So for the hip flexion contracture, we recognize that it's often important to correct. We choose to correct the femoral rotation first because often this will relax the, or result in some improvement in the hip flexion contracture. Our typical procedure that we advocate is one that's a recession. We don't release the psoas tendon off the lesser trochanter because of significant weakness. So we release the tendon from within the substance of the muscle, or an intramuscular recession procedure. There are several different techniques to do this, but the technique illustrated here goes from more of a lateral approach and rolls the muscle over. The neurovascular structures are quite close, and so this requires close attention. Femoral torsion, we recognize how to assess internal rotation on bench exam, but internal rotation is not the same as version. And the picture on the right shows that if you internally rotate the hip to the point where the trochanter is palpated to be the maximum, then assuming that the femoral neck is parallel to the ground, you can calculate that angle. So a patient may have 80 degrees of internal rotation, but their estimated anteversion may be 40 or 50 degrees. So taking note of that. So once again, internal femoral torsion is an osseous abnormality. It results from failure to remodel fetal anteversion, and it's corrected by an osteotomy. Here are some of the typical indications for the osteotomy. So you have very substantial increase in internal rotation on physical exam greater than 70 degrees, or inadequate external rotation for a normal foot progression angle. And these have been debated. The operation can be done proximally or distally. Generally, I do it proximally because if the cut is made above the lesser, you will relax the psoas. In a walker, you don't want to bring the neck shaft angle below 120 degrees. One thing to understand is that if you correct version 20 degrees, it doesn't necessarily mean that you'll correct internal rotation of the thigh 20 degrees, not a degree for degree correction. And it's common to have relapse of internal rotation gait at more than 5 years follow-up. And some of this could, of course, be technical, relating to the degree of correction surgically. A lot of it could be to dynamic muscle imbalance, the impact of the tensor and the anterior glutei, as well as the adductors. So it's a bit of a complex issue. It's rare in diplegics, but hemiplegics often do get dysplasia. So hip X-rays are always very important preoperatively. And if the hip is unstable, then whatever's required to stabilize this can be performed. The biggest problem at the knee is the flex knee gait, and I'll focus on that here. The stiff knee gait is treated by a rectus femoris transfer. The flex knee gait, it's important to understand that you can have different components to this. The hamstrings, an intra-articular block, or a capsular contracture, or both. And being able to distinguish between the two is very important. So hamstring contracture, we typically evaluate the popliteal angle, but this measurement in and of itself is not likely to be predictive of the need for hamstring lengthening. Remember that the hamstrings are an important hip extensor during early stance, and so over lengthening of the hamstrings can result in anterior pelvic tilt and as well as recurvatum. So normal popliteal angle is felt to be 0 to 50 in this population. Generally, a popliteal angle more than 60 degrees is felt to represent a hamstring contracture. Typically, we do a recession of the medial hamstrings. It's uncommon in an ambulatory patient to require medial and lateral hamstring lengthening. And if you do both medial and lateral, you're more prone to have an overcorrection, a recurvatum, and impact on the pelvis in general. The fixed knee flexion contractures, you can see there, is examined with the hip in extension. And this is a joint contracture. This is not going to respond to a hamstring lengthening. I typically do stretch casting for this. You can do serial cast, or you can wedge the cast as shown on the right. Posterior capsulotomy has been fraught with complications, up to 20% nerve stretch injury. So that has not been a commonly performed procedure, at least by the colleagues that I'm aware of. Guided growth is if you have time on your hands and you have a younger patient that you wouldn't want to do an osteotomy as an option. And for most teenagers or older patients, an extension osteotomy with retensioning of the quadricep mechanism. The guided growth gets you about 1 degree per month. And these are most commonly indicated for patients with a lot of growth left who have a sizable fixed knee flexion contracture. Typically, this would be best for contractures of 15 to 20 degrees. And so this is evolving. The distal femoral extension osteotomy is fairly straightforward. And this creates essentially a deformity to correct a deformity. The retention in the quadriceps can be done by advancing a bone block or by shortening or plicating the patellar ligament. And here you can see several patients who had painful stress reactions or stress fractures of the inferior pole of the patella. And once they were straightened out, these fractures healed. Below the knee, the rotation of the lower limb, it's common to have internal or external torsional malalignment. The external can involve both the foot and the subtalar joint and the tibial axis. Okay, so you can look at it in terms of the thigh-foot axis. That includes both the hindfoot and the tibial axis. That's a composite clinical assessment. Or the bimalleolar axis, which is attempting to estimate the true rotation of the tibial axis. And note that the standard measurements or typical measurements are different whether the knee is flexed or extended. So tibial derotational osteotomies, many different techniques are available. This is perhaps the most important thing in the ambulatory patient with spastic diplegia, and that's to not over-lengthen the soleus, because the soleus is one of the most important anti-gravity muscles. And when you lengthen the gastroc-soleus complex, being able to have different techniques is important, and also addressing upstream issues at the knee and hip are critical to avoid over-lengthening. Over-lengthening of the soleus will result in a crouch gait pattern. So you're aware of the silver skull test on the right side. In the upper image, the patient has the knee flexed. In the lower image, the patient has the knee extended. So in this case, there's adequate dorsiflexion with the knee flexed, no need to lengthen the soleus, but only the gastrocnemius is a little tight, so one can perform an isolated gastrocnemius lengthening. There are a lot of different ways to lengthen a heel cord. Zone 3 all the way on your right, lengthening the tendon itself is non-selective, does both the gastroc and the soleus, gives you the greatest correction but the greatest amount of weakness. In contrast, zone 1 lengthenings give you the least amount of correction but the least amount of weakness. So typically, the strayer that you can see there is an isolated gastrocnemius procedure. It's done in the proximal third of the leg, results in no weakening of the soleus. So what I was taught, typically in the diplegic patient, and sometimes if the patients are quite tight, I'll serial cast them before to give me the opportunity to do a zone 2 or zone 1 lengthening. So what Dr. Gage had taught me was the first component is to do your strayer procedure, and you can see there centrally how the tendon is released and lengthens, and then to reevaluate clinically. And if there's some loss of dorsiflexion with the knee flexed, then you can recess the fascia of the soleus. But the point here is that you've got a differential lengthening of the gastrocnemius and the soleus. So this type of a procedure allows you to fine-tune and minimize weakness. So equinovarus deformity, the key principle is that about a third, the tibialis anterior is overactive, tib post a third, and then some patients have both overactive. In the younger patients, there's some literature to suggest doing a lengthening and not a split tendon transfer, given the risk of relapse. In the older patients, maybe older than 8 years of age, the tendon transfer is appropriate. It's a split tendon transfer. We always recognize the need to get a full range of motion before doing our tendon transfer, and whether that requires soft tissue release or bony procedure depends on the patient. Split tendon transfers, your tib ant can go into the cuboid or peroneus brevis, tib post to the peroneus brevis, and in many cases, particularly when we don't have any information from gait analysis, the Rancho procedure has been advocated, lengthening the tibialis posterior with transfer of the tibialis anterior. The equinovalgus foot, the more rigid flat foot, is associated with the heel cord contracture. The hind foot is in valgus. And recall that the deformity of the hind foot is matched by the reverse deformity of the forefoot. So the hind foot is in valgus and the forefoot is in varus. You can see there that the tail navicular joint is uncovered, and there's basically eversion of the subtalar complex. The standard procedure that's been advocated for is that of the lateral column lengthening. That's a calcaneal osteotomy with insertion of a trapezoidal bone graft, reported to give a three-dimensional correction. But the important key points are that when you correct the hind foot, you have to assess the forefoot, because just like in a cavo-varus foot, except the opposite, that if the forefoot has a fixed varus deformity, then that needs to be corrected simultaneously, or else you'll have a relapse. So that requires either an osteotomy of the medial cuneiform or arthrodesis of the naviculo-cuneiform joint. And then also advocated is plicating the tail navicular capsule and advancing the tibialis posterior. The lateral column lengthening or calcaneal osteotomy, one can also perform this procedure as a distraction arthrodesis of the calcaneocuboid joint. I've done that in older patients. In patients who are GMFCS3 or above, who you're looking for stability, numerous individuals might advocate for an arthrodesis. I recognize that arthrodesis can lead to breakdown of adjacent joints, but a GMFCS3 patient will take about a quarter of the steps of an age-matched control. So in my hands, I've seen in the earlier years more relapse of the lateral column lengthening, so I've just done double arthrodeses. But this, again, is a controversial topic, and many people will disagree with me. So in conclusion, I think it's important to characterize each patient as an individual and try to understand the natural history or the trajectory for that patient and establish functional goals for treatment. Do a thorough clinical evaluation, choose the musculoskeletal impairments to address, identify the procedures and dose, do them under one anesthetic, and then recall that patients will still need braces and assisted devices. They need extensive rehabilitation, and we have to have realistic expectations. So I apologize. I hope I didn't go over, but thank you for the opportunity to give this lecture.
Thank you very much, Dr. David. Very nice, good information. Thank you very much. Now we need to move. Can you hear me, please? Can you hear me?
Yes.
Now we move to the second distinguished speaker, Professor Dr. Dalal Boubashir. She's a professor from Al-Imam Abdurrahman bin Faisal University in Saudi Arabia. He's well known to Iraqi Orthopedic Association, all different and always cooperative with us. So Professor Dalal will speak about the osteogenesis imperfecta treatment protocols. Go ahead, please, Dr. Dalal.
Assalamu alaikum. Good
Alaikum
evening. Of course, I'd like to thank all the organizing committee for this invitation. Coming last visit was amazing. We went through the cradle of civilization. You started civilization, so we're just catching up now. I had few questions coming from Iraq from a few of the consultants and the specialists asking about osteogenesis imperfecta and asking about the protocol, when to do surgery, what to do, what to give them exactly. That's why I decided to just put a protocol about management. It's just a small talk with general guidelines. It's not very specific. Everybody knows osteogenesis imperfecta. It's a congenital disease of type 1 collagen. Now, there are 20 causative genes that has been detected over the years, and the main two that are COL1A1 and 1A2. It leads to fragility of the bone. They heal with bowing of the bone and progressive deformities. And part of the progression of the deformity and the mobility is due to muscular dysfunction and connective tissue manifestation. As we all know, they present with blue sclera, deafness, abnormal teeth, which is called dentogenesis imperfecta. They have the typical triangular faces and joint hypermobility. And it increases risk of hernias, capillary fragility, and aneurysm, since it's also affecting the soft tissues. This is one of the famous patients of osteogenesis imperfecta. He's a motivational speaker. And he speaks to the crowd about what he's suffering with and how to help them move on. And this is one of the best books I've ever read, if anybody's interested. We know that silence has given us four types of osteogenesis imperfecta, but it has been modified into 7, where the highlight of the first type is being almost of normal height with blue sclera but normal levels of fractures. Type 2 is the lethal type, where they almost died within the first year of life. That's the longest patient has been reported. Type 3 is the severely deforming, which is the usual case who need our attention as surgery. Type 4 is similar to type 1, but they have moderate fractures and white scleras. Type 5 highlights are the radial head dislocation and mineralization of interosseous membranes. Type 5, where they are moderately short, they have scoliosis, and they have a hypertrophic callus when they heal. And the type 7 is where it's usually severe with rhizomelic shortening, so short humeri and femurs, where they're usually misdiagnosed as achondroplasia. The general guidelines of management is we know that there is no curative treatment, but it should be a multidisciplinary team where pediatric endocrine, pediatric orthopedics, physiotherapists, occupational therapists should be along the management, and to aim for maximum function, comfort, and decrease fracture as much as possible. So Dr. Gloria, since '98, he started talking about giving these children IV pamidronate. It took him a few years until he finally wrote a final paper on what to give and when to give it. And his final treatment is to start it as soon as 6 months of age. And he noticed after a few years of using that it reduces fragility and rates of fracture. It reduces deformity since you have less fractures, and it decreases incidence of scoliosis and need of surgery. If you have no deformity, there is no need of surgery. It increases the bone density and muscle power. So it's not only the density, which improves their function eventually. So there are a lot of papers that has been written on what bisphosphonate should be used for these kids. And that's the biggest meta-analysis paper with a systematic review. They reviewed around 427 papers that were available online. And then with the inclusion-exclusion criteria, it's a long paper. I'll just summarize that they used 223 papers that met the inclusion criteria, and they were testing everything that has been used with the different dosing, starting from 2009 up till 2004 up till current time, around 2017. And it was published in 2019. Their final conclusion was on the functional level, and they used something called the Black score, which I'll mention in a second. So for the oral, olpadronate or alendronate doses, even if you use them around more than 3 years, they did the same as placebo for the patient's function. They helped a bit with the mineral density, but they did not help on the long term using it alone or with surgery on the patient's mobility. But the IV, either the pamidronate or the zoledronic acid with the different dosing or spacing, increased their Black score around 3 scores in the first year. So I think that is greatly significant, because what we mean by the Black score is that the number 1 is non-ambulators at all, and number 6 are the ambulators in the neighborhood where they can walk around 300 meters. 2 and 3 are ambulators only by therapy and physiotherapy with or without crutches. 4 and 5 are household mobilizers. So if you start with a patient, let's say at the level of 2, and then you improve them 3 steps to a household mobilizer, either with or without crutches, you have improved their quality of life. Now, our protocol, what we do is when the patient first present, they present to the genetic or endocrine clinic, where they get documentation of their history and physical. They get genetic testing to be diagnosed as osteogenesis imperfecta. And once that being established, they start them on the pamidronate doses with their typical blood works. In the orthopedic clinic, for new patients, we again take history of the fractures, times of fractures, number of fractures, the deformity that the patient had, did they have any spine symptoms, thorough examination, and we do something called OI survey, where we survey, most importantly, the spine and the cervical spine, both upper and lower limbs, and a pelvis X-ray. Patient is being sent also for occupational therapy and physiotherapy to assess their muscle power. Once we do that, we start our pamidronate doses by endocrine, and it's done in day surgery because it takes 3 days to do that, and it's repeated every 3 months with oral vitamin D and calcium. Patients are being reviewed in our clinic every 6 months, where they have X-rays to be surveyed, and we arrange once they are qualified for surgery, the timing of surgery. Now, in between this time, if the patient gets a fracture, they are usually treated conservatively with a cast until they are ready for surgery. So timing of surgery is usually elective. We don't use their fractures as osteotomy since it's usually at a different level than we would like, and it usually causes more bleeding since it's a fresh fracture. The surgical goals are to obtain the optimal alignment of the limb, correct the deformity. Intramedullary rodding are the preferred method because it acts also as internal splinting. So if they have a fracture, we don't need to cast them because it's almost splinted. We try to give them a better muscle excursion for the muscles to move, decrease their pain, get a better longitudinal growth, and we start correction of lower limbs than upper limbs. We do both femurs, both tibias as soon as we can, and to improve their muscle function, improve their functional potential. Upper limb surgery is only done if they have non-union or if it is a fracture of the forearm. Timing of surgery, we prefer that the patient take enough doses of the pamidronate, and they can accommodate the smallest size of the rod, which is 4.2 millimeters on both X-rays, AV and lateral of femurs and tibias. If they have a very frequent fractures, so if they are around type 3 to 4, where they have more than 3 fractures a year, the severity of the deformity also guide us to the timing of surgery. Now about the bone quality, there was, as far as I know, no literature correlation between timing of surgery and the BMI of the patient, BMD of the patient. We don't measure it as a follow-up. The preoperative preparation, after the patient finishes his 8 dose or her 8 dose of pamidronate, a minimum of 2 years, preoperative pamidronate should be stopped 2 to 4 months before, and we resume it 4 months after healing because, of course, it decreases fracture union or osteotomy union. We have to check their cervical spine for basilar impression. We have to have very delicate handling when we transfer them in and out of bed. And the patient have higher incidence of malignant hyperthermia. So we need to alert the anesthetist. They should be first on the list, and the machines need to be flushed before we start surgery. We need to prepare a lot of packed RBCs if we're doing both femurs, both tibias, but still they tend to bleed, and we tend to give them blood. We prefer telescoping rods. Our highlight is the fascial dovile rod, and we correct the deformity with a modified Sofield procedure. Now, why telescoping rod? Why don't we use anything else? Because we know it has been tested, it has been used, and it has failed. These are patient has been following up in my clinic. So a rush pin has bent, a plate has bent, and a tense nail, sorry, but I don't know who even thought about it, in an osteogenesis imperfecta patient who has a very thin medulla and a very thin cortex. You can't even apply the principle of a 3-point fixation with a telescoping, or sorry, with a elastic nail in an osteogenesis imperfecta patient. So please, if you don't have a proper fixation for them, do not attempt to use any of these 3 fixations, because we are sure that it's going to fail. So what are the difficulties you're going to face in OR? First is the positioning of the patient, and this is from the webinar by Dr. Fassier. So you need to pad them very well. Pad the lower limbs, be careful of upper limbs, because any malpositioning can fracture these patients. You should remember that you have a multiple chorus and the nail is straight and the bone is severely bent. So you need to plan your level of osteotomy preoperatively. They tend to bleed, as I said. It's better to have a multiple procedure in the same surgery. So if we can do both femurs at the same time, if times allow for both tibias, if the patient did not bleed that much, then do them at the same time. Avoid using an oscillating saw because it tends to be too hot and too fast for the bone that is already fragile. So try to use drilling and an osteotome, it would be better. The medulla is triangular in shape, it's not rounded, it's very narrow canal, and then it might be obliterated with an old fracture, so you need to be careful. If you struggle with reducing the bent part, please do not try and manipulate it like we do with fractures, because if you try to force it in and you try to force the correction, then it definitely would break in an area you don't want it to break. So if you are struggling with the reduction, shorten a bit and reduce it with comfort. That's even better. You're not going to make him shorter than he already or she already is. For osteogenesis and spine, I'm not touching spine. We agreed with Dr. Thamer, I'm not touching spine until he teaches me. 40 to 90% of patients will develop some sort of a kyphoscoliosis from ages 4 to 20. So, but they tend to develop basilar invagination or fractures or spondylolisthesis. We know that orthotics wouldn't work with osteogenesis patients, so please do not try to use orthotics. If you are going to use a spine fixation, use a hydroxyapatite coated because it has a bit of a better function. Now, when do you have to fix their spine is if the curve is more than 30, younger patients, and higher BMI because they tend to bend as muscular imbalance, high BMD of less than -3. So a low BMD would tend to fracture and worsen. If you have deterioration of pulmonary function or neurology, then it is time to do some sort of a spine surgery. Just sharing two cases that I have seen in the past few months. This is a consultation from nursery as a 1-day-old child with an osteogenesis type 2. The child was born already with multiple fractures with the different levels of healing. So that's a typical type 2. It is lethal, and this child unfortunately died within 2 months. She couldn't even get out of the nursery. And this is a child who's 4 years old and he never walked. He started his pamidronate at the age of 2, but he had a poor compliance. But anyways, we could get him on the schedule finally. He only fractured his femurs. His tibias were never fractured, but they were so thin. And you can see the complexity of their deformity. It is not as simple as we think. And that's how his medulla looked on CT scan, where you can see his bone is triangular and the medulla wouldn't be only central. So in surgery, we faced a problem where his neck, the osteotomy level is too proximal, and his neck was almost a shell. There was nothing to be held. We could not use the Fessier technique to improve his neck shaft angle, so he ended up with a varus. I stole this from a colleague, Dr. Ibrahim, if you're watching, I'm sorry, I stole this. So even if we struggled, but we eventually got him into a straight femur on the right side and a straight femur on the left side. Now, we could not rod his tibias because the canal was only 3 millimeter, and the shortest or the smallest, thinnest slim rod is 3 millimeter. So that will be too snug fit to accompany that nail. So we're waiting on that tibia to be rod at a later stage, and we can, at that time, his bone will be stronger, and then we can do a revision either with the Fessier technique, or there is a new plate that is available, but it's freakingly expensive. We're thinking about it now. And just to have a happy ending, that was the patient's first few steps in the clinic, where he finally took a step. We gave him a bit of a shoe raise just to help him with that virus until we could do his final surgery. Thank you.
Thank you very much, Dr. Dalal, for this nice and interesting presentation. Dr. Dalal is Assistant Professor and Consultant Pediatric Orthopedic Surgeon from Imam Abdul Rahman bin Faisal University from Saudi Arabia. Thanks a lot. Now our next speaker is Dr.
Walid
Abdul
Al-Duri.
Majid.
He's
Okay.
okay. He's a consultant orthopedic surgeon and mostly interested in pediatrics. He's well known with experience with the DDH, and he was the past president of the Iraq Orthopedic Association. He's going to speak to us about, present to us a problem case of a big cyst in the pelvis or in the ilium. And you're welcome, most welcome to Walid, and please go ahead. The mic is
Thank
yours.
you. Thank you. Assalamu alaikum.
Alaikum salam.
أنا طالع دكتور محمد يمكم?
Yes, I can see
Okay.
you.
Thank you. Hello, everybody. Thank
Hello.
you, Mr. Organizer. Thank you, Dr. Mubder. Thank you all. I am honored to present my problem case as they told me to present. So I have a 17-year-old male who consulted me complaining of vague dull chronic pain in the left groin. It was radiating mainly along the medial aspect of the thigh down to the knee joint. Really, it was puzzled. Is it hip or knee joint? We were very puzzled. The problem really was of 4 or 5 months before he came to me. We investigated him thoroughly. On examination, really, I didn't find nothing more than slight wasting of the anterior thigh muscles. Of course, he was ambulatory. He physically was fit, apart from pain, especially night pain, which is not relieved by salicylate, of course. This is his left thigh muscles, a little wasted.
We cannot see your slides, Dr. Walid.
Cannot see the slide?
No.
Sorry.
Only the first one with the title.
Now, is it clear?
Yes.
Sorry.
Yes. 17 years old male.
Next, please. Next.
On examination, yes.
Yeah, good. Next, please. Only limitation, some painful limitation of the internal rotation of the hip, really. Please, next. Yeah, next, please. Next.
You can see the both thighs here.
Yeah, these investigations were normal. Nothing of significance. The next one, please. Next. Yeah, this is the X-ray. I think if we, sorry. The X-ray is clear now. Sorry, Dr. Muhammad.
Yes. I can
Yeah,
see
the
it.
X-ray. There is some lytic lesion in the medial wall of the acetabulum.
Yes.
If one can concentrate on this plain X-ray. Sorry, there is a problem in my computer, maybe, or.
No, it's
Okay.
clear. Okay.
Yeah, you said this is the plain X-ray, pre-operative. Please, the next, please, we send him for order a CT. Next, please. Yeah, this is the CT. Now, this is the lesion is clear, I think. This is the lytic lesion here, the medial wall of the acetabulum. Right? Is it clear?
It is, yes.
Clear.
It's not in the ilium, it's mostly in the ilium, yes. Yeah.
Ilium above here.
Above the scalp.
Yeah, but the main lesion was here. Okay, next, please. The problem was pain in the thigh, in the knee. Now, this is the report of the CT. It was suggestive of osteomyelitis. Next, please. Next.
MRI.
This is the MRI of the. Next, please. Next. Next, please. Okay. Yeah, the MRI report was in favor of osteoblastoma. Giant cell tumor is not excluded. Next, please. This is a short note about the nerve supply on the hip joint and the anterior part of the thigh, which is supplied by the anterior branch, as we all know, from the obturator nerve and some branches of the saphenous nerve. Next, please. Which might be irritated in this area, causing that agonizing pain. Next. Yeah, this is, you see the picture, all we know, this picture, the obturator nerve above, and this is the saphenous nerve. The EMG study was normal, of not significant. Next, please. We decided to go for open biopsy. Really, it was in my mind that it was a case of osteoma. This is the lesion. This is in the fluoroscopy during surgery. And this is the marker. This is the hip joint, and we went medially, ilioinguinal medially. Next, please. Yeah, as you see, this is the lesion. Well circumscribed. There was, it was bloody really. There was no pus, no granulation tissue, and a biopsy, irrigation, curation, and biopsy was taken. Next. This is the biopsy report. Yeah. We have two biopsies, two reports really, one here and one abroad. This one was suggesting that is osteoblastoma, osteoma. Next, please. That's the problem. The histopathology is very similar. It is difficult histopathological problem. In Jordan, it came with the result of osteoblastoma. Okay. Next, okay, please. Yeah, this is the patient. Okay. Now we will stop. That is the patient. We told them that the patient needs another surgery. And the family were very, very hesitant to do any intervention. They asked me to go abroad. I think Dr. Bourair is there. You hear me, Dr. Bourair? Sorry. Dr. Bourair helped us to see any center abroad, he know them, and we send the papers.
Yes, sir, I'm with you.
You remember the case, Bourair, and you sent the papers, right?
Yes, yes, exactly. I remember.
Exactly. Yes. And the family were very reluctant. They didn't want to go. And then we invited the coronavirus. So everybody was afraid to visit any hospital, and they remained here. And we being late for a few months. Next, please. But the patient still complaining of pain at night, not that severe, relieved by simple analgesia, and he's very active. Next. Next. Yes. Yeah. Next. This is the last. Sorry. This is the last. They visited me just before this meeting. After surgery. Please. Next. Yeah. This is the CT done a few months later. You see now the course is more aggressive. Now the lesion in the ilium more aggressive, as you see. Still the acetabulum is good, but the ilium is involved. There is destruction. Next. Yeah, these are a brief description of osteoblastoma. Of course, for all of us, really, it is the first event for me to tackle this lesion. So this lesion is a tumor, it's a benign tumor of progressive growth with a potential of local bone destruction and aggressiveness. Next, it is rare, of course. About 1%, yeah, it is 1% of all the bone tumors and about 3% of all benign tumors. Male to female ratio 3 to 1. The peak incidence is between 7 to 20 years of age. Next. 70% of the cases occur in the second and the third decades of life. The clinical symptoms lasting between a few weeks and 2 years, which are of boring pain. At this area, maybe before they consult any doctor. Next. Sometimes you might find local tenderness or swelling. The other thing, important thing, that the relief by salicylates, as with osteoma, may be intermittent only, or there is no relief by salicylates. This is the difference between blastoma and osteoma. Next, please. The course, of course, in rare cases, there are spontaneous or radiation-induced transformation to osteosarcoma. This is very important point. Really, it is not changing it to osteosarcoma. Either it is osteosarcoma from the start and misinterpreted as osteoblastoma, or it is osteoblastoma and they interpret it as a sarcoma. So some of them have been osteosarcoma from the very onset. It's not osteoblastoma. Next, please. So the treatment modalities, you know, for any cystic lesion, is there any role for radiation therapy or even local injections? I think the radiation would change it into a sarcoma. So it is contraindicated. Chemotherapy may be used for recurrent aggressive tumors or those which are surgically inaccessible locations. Next. The recurrent rate after whatever modality you use is about 10 to 20%. And usually those are of more aggressive behavior. Next, especially in children. The most common distribution in the body are the spine, especially the pedicles, and appendicular skeleton of the femur, also tibia, and most commonly involved. Next. Also, they are seen in small bones of the hands and the feet, in the skull, maxilla, clavicles, ribs, and rarely in the sternum. Also rarely in the ilium, of course. Next, please. This is the distribution, skeleton distribution of the tumor. Next. The diagnosis is sometimes difficult, and there is always delay of 6 months to 2 years from the onset of the symptoms, so that one should be always oriented about this tumor. So higher index of suspicion in children with unexplained pain would result in earlier diagnosis. Next. X-ray may be very specific. The lesion should appear as well circumscribed, rounded, oval, central, or slightly eccentric with an average size of 3 cm in diameter, not like in osteoma, of course. maybe 2 to 10 centimeters. Next. There is often resorption of the underlying cortex and protrusion into the soft tissues contained by a thin shell of reactive bone. This is what we found. Next. CT scan provides the most specific information, location, size, and differentiates it from other benign and malignant lesions. Next. MRI helps in evaluating the extent of the soft tissue involvement, especially in the spine lesions, of course, on the dura and the nerve roots. Next. Bone scan may demonstrate increased uptake, localization of the lesion, ruling out other lesions. Next, please. Chest X-ray may be indicated because there is a small risk, less than 5% of lung metastasis. Next, please. Although osteoblastoma may be associated with another bony lesions, including aneurysmal bone cysts, giant cells, even osteogenic sarcoma, which is rare, very rare. Next, please. They can be identical to osteoma, but it is, as we mentioned, larger in size. Histological differentiation can be difficult. It also not have the limited growth of the osteoma, nor the clinical or radiological features. Next. Due to local aggressiveness behavior, surgical treatment is indicated. So there is a new theory. I think you can help me, David or Dalal, that is the osteoma. There is a spontaneous healing after 2 to 3 years, which is different story from osteoblastoma. So osteoblastoma should be treated surgically. There should be intervention. So is it by extended curettage alone, in block excision, 4 steps, surgery, as we mentioned, radiation or chemotherapy? These are the surgical modalities or treatment modalities. Next, please. As we mentioned,
So the net is very weak.
Sorry, 15 to 30%.
The net is very weak.
Especially in young age group, and especially in more aggressive lesions. Sorry, Dr. Muhammad? Yes, what is next? Okay, as we mentioned, it is a problem. Take care. Next. So this is a summary as we...
Here the diagnosis is settled, Dr. Wali, isn't it?
Sorry?
Yes, please, go ahead.
Yeah, this is the home message. Go, please, next. This is the procedure which is now recommended, and this is what we did for the patient, as I told you, Dr. Muhammad. It is best treated by this, what's called 4 steps approach. This is written in the Journal of Pediatric Orthopedics. There is very scarce literatures about this subject, but this is all is known to all of us. Extended curettage, high-speed bear. We have high-speed bear, electrocauterization, and the use of phenol as we use in aneurysmal bone cyst. And we pack it by bone substitute. Next. Yeah, and this event really we would like to address and thank all the medical staff and medical doctors in their great effort in their battle. They are the white army against coronavirus all over the world. They need appreciation, and they need that we remember them in every event. Am I right, Dr. Muhammad? Next.
Of course, yes. Of course. Yes, we put our voices with you, yes.
Yeah, this is for Dr. Mubder, you hear me? This is the event of retirement of our beloved senior Dr. Hassan Kadam at November 1993 from Al-Wasri Hospital. He started his job at October 85 and he retired at November 93. I hope he is hearing us. He is with us now.
Thank you very much, Dr. Walid.
You know the group, Dr. Muhammad, Dr. Thamer?
Yes, yes.
Yeah. Okay.
Thank you.
Great, thanks, Dr. Muhammad. I hope I not took more time. Thank you a lot.
Okay, but now you are asking for a solution, are you, Dr. Walid?
Yeah, a solution. Yeah, I was asking about, but due to the shortage of time, yes. I mentioned that we did the first step intervention.
Yes.
Yeah.
But first of all, the diagnosis is settled. It is a benign lesion.
Sorry, diagnosis is osteoblastoma.
It's settled, osteoblastoma, benign lesion.
Yes. Yes.
Okay, and the patient is better generally, or slightly complaining. Yes.
Yeah, yeah. The patient is freely mobile, apart from slight pain, relieved by simple analgesia, and no other problem.
But the cyst is not obliterating spontaneously.
No, no, no. That is against osteoma.
It is not.
It is aggressive.
Is it expanding? You think expanding?
Yeah, it is expanded in this time, this lag period.
So what step you need to do to reverse the erosion of the bone or the expanding? The bone graft is a logic solution. Yes.
If the facilities is there, when you go, really we are not prepared for this surgery. We went for, as I mentioned, we went for open biopsy.
You already went there, yes. Why not?
I know. The plan, I mean, we went from the start for open biopsy. We were we were not prepared to do this final surgery. But if we have the facilities of a frozen section, you can go directly for this surgery, and you can do your surgery. But of course, we have no frozen section, so
so two-stage
to await for the histopathology.
Dr. Muhammad, can I remark if you don't mind?
Of course, please. Yes.
Yeah, I think, I don't know, I'm sure Walid is experienced orthopedic surgeon, but I don't know whether he excised the lesion intralesional or he cut the surrounding borders. Did he take a safety margin? Or he took the lesion, we call it intralesional excision, that's one. If I were him, I will fill the gap by bone cement. And bone cement is very good to kill what remains of the malignant cells in the surrounding. Moreover, it stops bleeding. And it's good even for relieving pain. So this is my personal feeling.
Thank you. Can I answer, Dr. Muhammad?
Yes, sure, please. Yes.
Thank you, Prof. Thamer, for this remark. Really, I did a curettage of the whole intralesional of the whole lesion, and there was no granulation tissue. There was no pulse, and I took all the sample for histopathology irrigation. I was not thinking at all of putting bone cement. Bone cement, we use it as a temporary, not final.
It is,
number one.
Yeah.
Second, if there is a possibility of infection, I think it's difficult to decide to put bone cement. And third, you have to go in another time and remove the bone cement and you put bone graft. And we were not sure about the diagnosis. So really, I was not prepared for any option except to explore the sea and to take a biopsy. Thank you.
My question is not the curettage, but to take a safety margin. And moreover, to get biopsy from the safety margin to be sure that the lesion was completely removed and the margins are healthy. I think I have good experience with bone cement. Infection-wise, it doesn't increase the chance of infection. And this is not an infected lesion to make it worse. And yeah, I know it is temporary. You can easily go again and take it away if it is something else. So anyway, you know, اختلاف أمتي رحمة.
إن شاء الله رحمة. هو هذا السبب اللي قدمنا هاي الكيس نستفاد من خبرتكم. ثانيا, I was not oriented or not thinking of it as a malignant tumor. So I don't need to take the margins or safety margin. It is only that in the cavity. And the bones were healthy. Nothing was there in the bones. So I never thought about taking.
You cannot tell the margin is healthy from macroscopical appearance. You have to take a biopsy from the margin for histopathology because the lesion might be microscopical. It looks healthy to your eyes, but it is not healthy to your microscope. So this is my feeling.
But osteoblastoma, you know, sir, it is a benign tumor. And the proof that was osteoblastoma. Second, I use bone cement in giant cells, always. In giant cells, I use it as temporary for the thermal effect to kill the cells. And then I pack it with bone graft after 6.
But you said already there is recurrence. So by putting bone cement, probably you can halt the recurrence, right?
Sure.
Recurrence because of incomplete excision.
Sure.
Why it recurs? Okay, thank you, Walid. I don't want to take more of the time.
No,
thank you very much.
Good
lesson. Good lesson.
Yeah, so, we want to learn from you all. That's why I present this case.
We learn from each other.
May I ask the other distinguished speakers if they have opinions?
Ustad Hassan is waving his hands.
Is he?
Ustad Hassan Kadhim Muyana, and he wants to say something.
Okay. Hello. Yes. Go ahead. Go ahead.
Before I ask Dr. David, I should give my regard to Dr. Walid. He reminded me my retirement.
27 years ago.
Anyway, this is very good opportunity to me just to see somebody always remembering the past. And we will have from the past many experience. Anyway, my question to Mr. David, what he does for the calcaneus foot correction in regard the bony and regard the muscular balance after the correction of the bone in his CP's cases. Please. Hello?
Can you hear me?
Did you hear me, Mohammed?
Yes, I hear you. But what about David?
Yes.
Okay, I've unmuted. Can you hear me?
Oh, yes, can hear you.
So
yes,
our teaching has been that when treating the equinus contracture, that the biggest thing to avoid is the calcaneus deformity. And the calcaneus deformity comes from unnecessarily lengthening the soleus muscle by heel cord lengthening. I don't have any solution for the situation in which there is a calcaneus deformity, except we tend to use a solid brace to prevent the tibia from advancing over the foot while the patients walk, because this will be the cause of the crouch gait. So for us, the teaching is to try at all costs to prevent the calcaneus deformity. And preventing it means number one, addressing the contractures and problems that occur at the hips and the knees, and then to select a technique to treat equinus that minimizes any risk of over-lengthening the soleus muscle. So doing the Strayer type procedure. But
Okay.
I'm not familiar of doing any surgeries to treat the calcaneus. I suppose I just am not aware, because we typically use a solid brace for that.
This is actually bring my attention to the orthosis. What is your experience in CP and in the spastic condition with the orthosis? Because I felt the orthosis never helped too much in spasticity rather than in plasticity, which we always face in poliomyelitis.
Right.
Yes.
So we use the orthoses for a variety of reasons, depending on the amount of spasticity and the function of the child. Some patients who just have a drop foot during swing phase and they're having trouble catching the foot and tripping, then we use a simple, a lightweight carbon fiber orthosis, or we use a solid AFO orthosis with a hinge. In order for an orthosis to be effective, the patient typically shouldn't have very significant bony rotational problems. So if a patient has a lot of torsion of the tibia or femur, particularly of the tibia, they might not have as useful a function with the orthosis. Now, in the patients who have a lot of tone, granted, in our environment, they're also getting management for that muscle tone. They may be getting beforehand some stretch casting. They may be getting Botox injection. The second thing is that in the patients who are walking with a flexed knee gait, whether you call it a crouch pattern and their foot is flat, or whether they're up on their toes, often, particularly for those with a crouch pattern, a solid brace is very helpful to us because it prevents the advancement of the tibia over the foot, and it directs the ground reaction force backwards to try and keep the knee extended. So we use different types of braces of different thicknesses and designs specifically for different indications in cerebral palsy. And what works for some very young patients with a simple drop foot is very different than what is useful for, say, a teenager who's heavier weight, whose soleus is over lengthened, and who's walking with a flexed knee gait. The other thing is that our patients tend to be, especially, I think maybe more so patients who are living in a city or a very urban environment, our patients tend to be more receptive to using orthoses. Whereas, for example, in my experiences in Nepal, patients who are coming from the villages in different environments, they do not tend to use the orthoses.
Thank you.
Thank you, Dr. Hassan. Thank you, Dr. David. Okay, Professor Hassan.
Thank you very much.
Thank you.
I mean, perhaps I will leave the time for my colleagues to ask, but if you don't mind, I have a question to Professor Dalal.
Okay.
Dalal.
Yes.
السلام عليكم.
Hello,
كيف الحال
hello,
أستاذنا؟
Hello. I actually get a bit difficulties, a pre-operative assessment of the care, particularly with the femur, and pre-operatively how we assess the care as a bony and how many osteotomies you have to do, and even sometimes we have to get part of the bone to be missed. For example, in a shish kebab, maybe one piece, we may remove it because any correction in the bone, we may get obstacle with the soft tissue. in the concavity side. What is your experience in this situation?
So for pre-op, that's a full lecture on its own, the surgery and the assessment and where to cut exactly. We usually just do an AP and lateral, and we have a digital templating on how to cut and where to cut. If you don't have that, you can do a 3D CT scan where it helps you to imagine the full deformity of the bone. That's a more accurate thing. Otherwise, you will open and see, and you can shorten. Yes, shortening helps a lot in reducing and keeping the bone straight, and it will not affect on the long term because you will almost do the same thing on the other side. So there will not be limb length discrepancy.
And perhaps you do the same thing with the tibia.
Tibias usually have less, but yeah, most likely you will do the same in both femurs, both tibias. So limb length will not be a big issue.
Delal, did you try at all, particularly for the tibia, multi-osteotomies with fixation with the external fixator?
It hasn't been even mentioned in papers because external fixators their bone is very brittle and it will not hold.
Anyway, particularly with the tibia, because tibia is the curvature is the anteriorly like saber tibia, and actually I have tried the external fixator, and even we did a multiple osteotomy, and each piece will be fixed by one pin, and without drilling, you see, we go directly.
Yes.
And it was really, anyway, because in our country, the nail you are using, it is very expensive.
It is.
And the point I just tell you as an innovation for myself, I don't use really the nail you are using because it is expensive. Perhaps some of the company doesn't like my comment. I use two K-nails, one smaller than the others, and slide the one which is smaller with the longer one, fix the bone, and fix the smaller one at the end with the small wire. So with the growth, there will be sliding.
Yes.
Get it? You got it?
As long as it is a stronger bone, like two rush pins on opposite to each other. So that's يعني practical. يعطيك العافية.
شكرا عيني.
Thank you, Professor Dalal, and thank you, Professor Hassan. I think we need to move now to the last but not least speaker, Dr. Ali Baqir Al-Hilli. He's assistant professor in the College of Medicine of Baghdad. He's working at the Medical City Complex of Hospitals in Baghdad. He's going to speak to us about mismanagement generally in pediatrics orthopedics. Go ahead, Dr. Ali, please. Did you hear me, Ali?
Yes, sir. Yes, sir.
Welcome. Okay.
Chairman.
Go ahead. Thank you very much.
Thank you, sir. Do you have my screen?
Yes, I have. I can see you, hear you.
Thank you, Mr. Chairman. Thank you, organizing committee. Today, I'm going to talk about an experience. It is case-based. It's all about pediatric orthopedics. I need to know a problem and what is the cause of these problems. So I have no disclosures related to this talk. Our objective today is to know what is the mismanagement in pediatric orthopedics. Mismanagement it is not sure comes from a surgeon alone, it comes from multifactorial. Who we should blame and what are the solutions? So we all agree that children are not little adults. Children are totally different, different in everything. And we need to treat children in a different way from than adults. If you are treating adults and children, we need to reset our brains each time and go to the right to the pediatrics or left to the adults. Children can accommodate anything. You can do them anything, any intervention, and they can sleep quietly. But the problem, sometimes we do the work in the wrong way, and we need to know whether this is right or wrong. So who decide for treatment in pediatric orthopedics? Definitely there are many people decide, but it's mainly comes from the family and the orthopedic surgeon. There is a huge debate and conflict between family and orthopedic surgeon. And if the family wins, there is a problem. If the orthopedic surgeon wins, it's okay. But what if this surgeon is not well qualified to treat pediatrics? So regarding the children, you have the father might have an opinion, a mother. The problem, you have two grandfather, two grandmother, and then the relatives sometimes comes, and the neighbors comes, and sometimes even the ambulance driver have an idea about the treatment, and the least who choose treatment for himself is the child. This is a problem. So what's mismanagement? It's the process of managing something badly or wrongly. Let us go very quickly through few cases. The first one is bone infection. This is a 2-year-old male. He comes presented with a sudden inability to move his right upper limb.
Hello.
There is a low-grade fever.
Hello.
There is no history of trauma. He treated by orthopedic surgeon by back slab for 1 week and tell him this is just, sprain or so. And then his fever increases. He went to another orthopedic surgeon, sent him for ultrasound and investigation. And he told him this is a bone infection, you need to do surgery. Family refuses. Then went to another orthopedic surgeon who said, you don't need to do surgery, go and give him antibiotics only. And after that, the child presented 27 days later with this X-ray. And clearly you can see there is a frank signs of periosteo reaction. The baby is suffering from pain, he has fever, and then the family told surgery should be done. The family refuses again, and then come presented 1 week later when there is a fluctuating mass in the right arm. Now the child looks better than previously, and this is his X-ray, and you can see the mass is over here. So what we do now, just we puncture this skin and take the pus out, and that's it. And then he comes again with the normal ESR, CRP falls down to normal, and he now start healing, and the bone 6 weeks later is almost there. So what happened? Who should be blamed for this? Is it the orthopedic surgeon? Is it the family? We don't know. We need to think. And another case, this is a trauma case. 5-year-old female, history of fall from height 2 meters in October. And the patient complained from knee pain, but the problem, she cannot bear weight. So went to the clinic, took X-ray, told her the knee is normal. You don't need to do anything. Just put her in a slab and then analgesia and discharged home. Comes later on, she cannot bear weight also. And now the surgeon sent for pelvic X-ray. And this is the pelvic X-ray. The problem is we have a fracture in the neck of femur. And we need to do something for this child. She cannot stand and walk normally. So the orthopedic surgeon decided to treat her by spica cast for 6 weeks. And then after removal of the cast, we have almost 3 months gone. Still the fracture is not united and the neck has got to resorption. CT scan shows clearly there is a fracture, and the MRI shows that the head is still viable. So we went and do this surgery. We do just osteotomy just to enhance healing and using some implants. We don't have the fancy implants, but simple plates and do the osteotomy. Then we got union, but we can avoid this by managing this case in the right way. This is another case, 9-year-old female, the history of trauma and hip pain 3 weeks ago. And the X-ray shows that clearly there is a slip of the capital femoral epiphysis. They went to orthopedic surgeons. Someone told them we need to do surgery. Another one to leave her alone. You don't need to do surgery. And the family accepting the conservative. Then the pain increases after 2 weeks. She came back with increasing slipping. We tried to advise for surgery, but the family refuses again and take the baby and run away. So who should we blame? And last case, 8-year-old female with history of trauma to the knee 3 weeks ago. And this is the X-ray. And you can see here clearly there is a bulging of the tibial spine. And the CT scan shows that the piece is almost, rotated. And she came with a locked knee, 30 degrees and painful, and treated by cast for almost 3 weeks. So who should be blamed for this? How can we solve this mess? It's a really mess and headache. So today, if we count the cases, if we try to think about the cases, we have mistakes and mismanagements from 4 orthopedic surgeons. Definitely there are board certified. Where is the problem? The problem from the postgraduate training, from graduate qualification, maybe. Then we have 2 cases. We need to blame the family about that. Maybe the healthcare system is not good enough to treat such kids, or it could be a shared responsibility. So an orthopedic surgeon should ask himself, am I qualified to treat pediatrics? Am I board certified? I need to be a board certified to do that. Then the most important thing, I need to like pediatric orthopedics. Then I need to go and do an orthopedic fellowship program. And then I need to continuously reflect, educate, and discuss. And the least thing I should think about is money, because all you know that pediatric orthopedic is not worthy. It's not just like joint replacements or the spine surgery. You need to go with the family and do a family education program. You need to spend time discussing, and you need to give them some compassion, and you need to speak with them in a common language. You need to tell them the whole story. What will happen if we leave the child without treatment? What about the healthcare? People responsible for the healthcare system should know that treatment of pediatric orthopedic should be in a center for pediatrics. It's not something good to treat pediatrics among adults. It's not nice to have an adult clinic and then a patient with osteogenesis imperfecta comes alone among all of those patients. You need to have clinics responsible for treatment or everything. Even the pediatric subspecialty should have a subspecialty. The pediatric physical therapy is different, definitely. And then CP needs to have a special clinic. And then organizations, dealing with the pediatrics and arranging annual meetings with education. What about our postgraduate training? Are we doing something good in our country? Are we treating pediatrics in the right way regarding our trainees? And we need to have a fellowship program. And this is a point that we are discussing with our colleagues among the country, our friends everywhere, to have a fellowship, a pediatric fellowship program in our country, teaching our residents and trainees how to be a pediatric orthopedic surgeon, because a pediatric orthopedic problem should be managed by pediatric orthopedic surgeon, but he should be a real pediatric orthopedic surgeon. Thank you, Mr. Chairman.
Thank you very much.
Can I remark, if you don't mind?
Yes, of course. Please go ahead.
Yeah, Dr. Ali.
Start.
I have a long life with Ceftriaxone. And I add my voice to you. It is a very good antibiotic, no doubt about this. But my question, what about local application of the powder of Ceftriaxone, say in a septic wound? Is it useful?
نعم Ustad, frankly, I have been through a clinical trial that investigated local injection of Ceftriaxone, meaning that it is dissoluted Ceftriaxone in the vial and injected or infiltrated locally into the subcutaneous tissue or muscular tissue around the operation site in case or in purpose to eradicate any possible or minimize the possibility of postoperative infections. And the result was favorable, of course.
Okay, but no,
however,
okay,
yes,
anyway,
you mean
Ali,
the powder. You mean the powder.
Ali, let us make the question short and the answer short. Okay,
Yes.
so that we give chance for the other to speak.
Yes.
My question, local application of Ceftriaxone powder, say on septic wound, is it useful or not? We don't know.
I don't know. I don't know, of course, because this is not approved use of using Ceftriaxone. Ceftriaxone needs to pass it through the liver and being metabolized, and the dose is calculated accordingly. So having the powder directly on the wound, I don't know, and I can't answer you, Professor.
Okay, second thing is, can we inject Ceftriaxone in the disc?
In the disc?
Yes, in the disc. For example, we take the nucleus and then we inject, because we inject gentamicin. There was no problem in injecting gentamicin. But my question, is it safe to give Ceftriaxone inside the disc?
Again, Ustad, unfortunately, I have the same answer. We have no data supporting such use, and you may use it according to according to your experience.
Make a search on these 2 points. This is very
Inshallah.
Second thing, I don't know whether you have stressed on or not.
Yes.
Ceftriaxone should not be given directly in the intravenously, because we have many bad outcomes. So it should be given through a fluid, 200 cc, and you dissolve 1 gram in 200 cc, but never give it as a shot. We have a patient collapsed after giving the Ceftriaxone.
If we follow the manufacturer's recommendation, in case Ceftriaxone can be given intramuscular, intravenous infusion, as you said, and intravenous injection, but a slow intravenous injection over 3 to 5 weeks.
No, Ali, you cannot guarantee this. You know, our dresser is not keen. So the safest way, that's what I want to insist.
Yes, safety-wise, it is better to give it intravenous infusion مثل ما تفضلت استاذ.
Yeah, that's important points. And tell me about the 8 hours, from where it comes. Is it depending on research or it's presuming?
In the study I showed, yes.
No, you said better. Ali, you said it can be given at the time of anesthesia, but I'm against you because we did a study. We give Ceftriaxone 2 hours prior to surgery, okay? And we give it at the time of anesthesia, and we did discectomy. And we took the disc and we analyzed the concentration of the Ceftriaxone in the disc. And the concentration was much better by 2 hours rather than at the time of anesthesia. That's for your interest.
It takes some time. استاذ حضرتك اعرف انه الانترvertebral disc is an avascular tissue.
In adults.
It takes in adults, yes. It takes some time for any antibiotic to enter the intervertebral disc by diffusion, of course, from the surrounding vasculature, and of course it would take time. However, the study I showed in my presentation, it wasn't in the intervertebral disc, it was in the femur, total hip replacement, head of the femur. So the maybe due to the relatively better vasculature, giving Ceftriaxone even 8 hours before the operation resulted in sufficient concentration in the bone and surrounding fatty tissue. And of course, giving it at the induction of anesthesia resulted also in sufficient concentrations. And the study concluded that both scenarios are sufficient. This is the specific study, but about your study, the story may be different, sir.
Okay, that's very kind of you, appreciated. But anyway, I said to you, Ceftriaxone is very impressive antibiotic, and I'm a good friend to Ceftriaxone.
معلوم أستاذ. We know that.
To be honest with you, but I think still we need to do further study about Ceftriaxone.
Yes.
Yeah, because we can broaden our local experience with Ceftriaxone MIFA. We call Ceftriaxone MIFA because it was MIFA before ASINO. Thank you, Dr. Muhammad Ali, for giving me long time.
It's okay, Thomas. Thank you very
much. Vital points.
You're welcome. Any other speakers want to comment on this important antibiotic? Any of the myself, I use it a lot, but I haven't done any studies, but it's good. It's a prophylactic and it's good for treatment in bone infections and bone. Well, this is the point. Allergy, if you give it quickly, this is the important point. Do not give it as a shot. Very slowly, infusion. Yes, Walid. Go ahead.
العفو. شكرا دكتور علي. شكرا أستاذ ثامر. Really, there was some misfortune. You know, I don't want to bother you, but there was 2 cases mortality after being given Misporine. And I want your opinion about this.
Ustad, the Misporine by name or other Ceftriaxone?
I think Misporine it was.
It wasn't reported to us. However, assuming that it was Misporine by name, so most probably the patient had original or genuine Ceftriaxone hypersensitivity.
Well,
and in this case,
really,
even if it was given intramuscular, it would be lethal for them.
It was not my cases, but we heard about this, and somebody told us to stop because it was recorded, I think, even in the Ministry of Health at this level. Maybe it is not your company. I cannot criticize you.
In fact, too many cases of Ceftriaxone and cefotaxime hypersensitivity reactions and anaphylactic cases, and even unfortunately mortalities resulted. And we as a company have investigated the cases. Up to our knowledge, up to the reports that were reaching to the company, we had no case with the Misporine, apart from maybe 1 case of mild hypersensitivity, and the patient admitted that he is hypersensitive to Ceftriaxone.
How do the patient know he is hypersensitive?
والله استاذ قال الان يعني كانت تصير عندي من اضرب ابر.
Anyway, but Walid said the truth. Yes, there is mortality.
ما شكت استاذ وليد، لا ابدا. بس النقطة اللي اريد اقولها انه too many generics of Ceftriaxone are available in the market, and many of them are not examined by the Ministry of Health. يعني ما عبرت ال QC examination unfortunately. فmaybe يعني ما معقولة عدد الحالات اللي صارت هي كلها hypersensitivity to Ceftriaxone، واللي هي المفروض حسب الليترشر ما تزيد عن يعني 1% من البوبوليشن. However, maybe the additives, the ingredients other than Ceftriaxone in the vial, maybe they are the source of hypersensitivity, and I don't know.
No, I think to be again on the safe side, and you know safety comes first.
Yes.
You have to give a very small dose, subcutaneous.
Of course, this is the ideal
situation. There is reaction. If reaction happens, this means that the patient is allergic, and you don't give him further.
Totally agree with you, staff.
And you did not mention that in severe infection, we have to give 2 grams, but a single dose, not a divided dose. Not.
That's why احنا جبنا 2 gram vial, staff. دخلناه للعراق. 2 gram vial.
Yes, it's there.
Dr. Thamer, very nice idea, and it is routine now, I think, in the hospital.
Much better.
Sensitivity test before they give the Ceftriaxone.
Yeah, that's true.
That's true. This is routine. Now this is routine.
Dr. Walid, you remember in UK when we were registrar, when the patient admitted, for the interest of everybody, they put betadine on his skin, and they put a zinc plaster on his skin a day before surgery, so that next morning when he's ready for surgery, they check the plaster and the betadine. If he's allergic to this or that, then they don't give him. And this is very easy job to do. Okay?
Yeah, sure.
Yeah, okay. Thank you, Ali. Thank you.
Thank you. Thank you.
Thank you very much for these comments. Now we have a few questions from several colleagues to the speakers. Can I start with David?
Sure.
David, are you ready?
I'm here.
Yes, there's a question from a colleague. He said, when you have spine deformity with the limb deformity, would you start with the spine first?
Yes.
You start with the spine first.
At least in my experience,
Yes.
progressive spinal deformities have typically occurred in the GMFCS 4 and 5 patients, rarely, if ever, in the other types. And so, in those patients, the typical problems that we see are progressive spinal deformity in association with either instability or displacement at the hips and lower extremity contractures. And I've heard arguments for and against addressing one or the other first. In my typical practice, I've operated on the hips first and then the spine second, but that's not exclusive. In the patients that I was talking about in the lecture, in the ambulatory patients, the GMFCS 1 through 3, I've not, at least to date, had to address any progressive spinal deformity. So typically I'm just doing lower extremity work. So I hope that helps.
Thank you. There's another question. A colleague asked, have you tried Elizarov technique for knee contracture or knee flexion contracture?
Right. That certainly sounds like something that would be appropriate, because I recognize that in our management that we, when doing an osteotomy, be it a shortening osteotomy or shortening and extension, we create a subtle deformity to treat a deformity. I typically do serial casting in advance of osteotomies because I'd like to get the fixed knee flexion to less than 20 degrees so I don't have to do a big or create a big deformity to treat one. I think the advantage, one of the issues with realigning the knee is that there's patella alta and an incompetent quadricep mechanism. So my training has been to retension the quadriceps at the time that you get the knee straight. And so typically an extension osteotomy and a patellar ligament advancement is an hour-and-a-half case or so, and done in concert with other surgeries. So I think technically many of you are quite, are a bit ahead with management with Elizarov compared to, I guess, me and my colleagues, because there's less of a demand, but I think it's possible.
It's an option. Thank you very much. I have a couple, another two more couple. Anyone to comment on that, please? Yes.
If I could make a comment, if you don't mind.
Yes.
One thing, if you're going to do the distal femoral extension osteotomy, shorten the femur. You'll increase the stretch on the sciatic nerve if you don't do that, and the results can be terrible. It's extremely difficult for them to recover from that. So when you extend that, the good news is you're usually doing it bilateral, and don't hesitate to shorten the femur. Don't just take a wedge, take a trapezoid and shorten that. It'll allow a lot more flexibility, and the cases that I know of that have stretched the sciatic nerve have been awful. So just be cautious about that.
Yeah, thank you.
That's very important, and I hope I mentioned.
Sorry, Dr. Mohammed. Sorry.
I was going to say it's very important to mention, and I hope that I had mentioned, but I shorten every single one 100%, usually about a centimeter each, and knock wood, I haven't had a nerve stretch at least to this point in time.
Thank you very much. Yes, Walid.
Thank you. Sorry, thank you. اولا بس دكتور علي الحقيقه مو عندي الكيسات مال المورتاليتي، يعني سمعت عنها حتى لا مال المسبورين، يعني هاي سمعت عنها، فلهم يعني يستفادون من هالمعلومات. الشيء الاخر النيرف انجري سكوت، اني once I faced this problem really, I admit I did one case neuromuscular extension supracondylar osteotomy with implant. The left side, I think I did shortening and went very well. The right side, the patient, I really did under tension, the correction. Second, third day, the patient, the foot is a flyer. And really, after 1 month, less than 1 month, I explored the popliteal fossa, and I found that there is severe traction injury to the common peroneal nerve. The posterior tibial nerve was good, intact, no problem. The common peroneal nerve was severe traction injury. And now he has a foot problem. I admit that one of the pitfalls in practice, Dr. Thamer. This is my second admission. I admit that I did this problem for the patient.
Thank you, Ali. Thank you very much, Ali. Thank you.
Mohammed,
Yes, yes, Hassan, yes.
actually, I want to elaborate a bit about the problem of to do extension to the knee. I mean, and assess the patient in generally, not locally, not only the knee, if it is right or left or both of them, because sometimes the patient, whatever you give him for extension, he will lose the flexion. Instead of his getting the extension, he will lose the extension. Because in the long run time, we've been very enthusiastic with any patient with a deformity. We say, we treat him, particularly with the people that are on wheelchair and they are happy with the flexion. So we did, wrongly it was at that time, we did the extension, both of them, and the patient lost his flexion. So he remained with the extended leg. And he came later on, he said, it was better to me to be with the flexion functional position, not in the extension, and as we regarded in functional position, not in extension. So I think we should be aware, not always to say, we give him extension, of course, to do the extension not by force, to regard the nerve, we may do shortening, do fixation, and you do enforcement for the quadriceps. This is combined with the surgery. But always we should wear the patient and we should wear ourselves. Whatever we give you, you may lose it. I don't know what is the experience of David in this situation, or my colleague, the first one who talked about the CP.
So I think you're absolutely right that when one does an osteotomy for realignment, you're creating a small deformity to correct a deformity. So I try to minimize the amount of correction required so that, as you said, when you get extension, you take from flexion. The only reason for doing osteotomy in my clinical practice is a teenage patient who's losing the ability to ambulate because of a flex knee gait with a fixed knee flexion contracture. I have colleagues who, in patients who are GMFCS4, who have done this operation solely to preserve the ability to independently transfer, say, from a wheelchair to a bed. So it's always a functional indication, preserving ambulation or for a specific task, and then by minimizing the amount of correction required for the osteotomy, then you minimize the amount of flexion that is stolen. So in my experience, none of the patients that I've done the operation on have not been able to flex their knee 90 degrees to sit in a wheelchair. But I agree with you. If I correct a 20-degree flexion contracture, then I'm going to steal 20 degrees of flexion. So preoperatively, it is important to make sure that you've got that range of motion to steal from.
Thank you.
Thank you, David. I have two more questions. Can you hear me, David, here, please? Can you hear me?
Sure.
I'm sorry, I was off the net for a few moments. A colleague asked, what's your experience with hamstrings to distal femur transfer?
Yeah, and I'm going to ask Scott for help with this. I have read about it in a few articles, and I'm aware that some of the leading thinkers are doing it, but I don't personally have any experience with that technique.
I have, I've done 2 cases, and it is successful, very good in treating flyal knee. When you have, when you have a weak quadriceps. I think it's useful.
So you're transferring it to the adductor tubercle?
Up to the femur, yes. So to keep it to do extension of the femur, yeah. Mainly extension without flexing the knee. So it helps with the hand-knee gait.
Dr. Muhammad Ali, do you anchor it to the bone or you anchor it to the quadriceps? What do you do? Where when you transfer it?
No, to the bone.
Anchor it?
To the bone, to the femur posteriorly, to keep it as an extensor. From the tibia to the distal femur.
Sorry, you said you anchor it posteriorly to the femur?
Posteriorly, it is posteriorly, yes. Yes, posteriorly. So it acts as an extensor.
So the idea is to minimize the impact.
Yes, Hassan.
Sorry. Yes, sorry.
Who wants to speak?
Dr. Muhammad, sorry. David, sorry.
Well, David is speaking.
Sorry. Yeah.
Then Hassan, then Walid, okay?
Well, sorry.
Yes, David, please.
I apologize. I was saying that, so then the goal of the surgery is to prevent the weakening of hip extension during stance phase, I guess.
Yes.
Or at least the function of extension.
Yes.
Good idea.
Thank you. Yes, Dr. Hassan, please.
Sure.
Yes, Hassan.
I want to elaborate about the idea of Muhammad mentioned, which we get the flexor of the knee to the femoral condyle, either bilateral flexor or unilateral, and this was being done with Professor Eggers. It is very old surgery, and it is beneficial because it will extend the hip, it will extend the knee, and get the patient straight. But I don't know, this surgery completely absent from the orthopedic books. But I haven't tried it, and it is an Eggers operation. Thank you.
Thank you. Walid, you want to comment?
Sorry, I quite agree with my senior, Dr. Hassan. It is called, Dr. Muhammad, it is called Eggers procedure.
Yes,
It is called when you transfer the hamstring into the quadriceps, really. You want to augment to make it more powerful, the quadriceps.
But
and then they found that it is inefficient. So it is absolute now. Nobody is practicing it by now, I think. This is Eggers procedure.
Yes, but what we are talking about, not Eggers, not to the hamstring, but to the femur.
Yeah.
To the bone, to the femur, not to the hamstring. Okay.
But I want to ask David, sorry. Mr. David, you do plication of the ligamentum patelli when you do extension of the knee joint?
Yes.
You tackle the ligamentum patelli, please?
Yes, I do retensioning of the quadricep.
Yes.
That was initially taught to me as a bony advancement in patients who are skeletally mature. In patients who are skeletally immature, you can advance the ligament itself along the tibia. And then there are also some authors who advocate simply plicating the tendon without advancing it. I'm not sure there's science to support one over the other, but I would ask Scott what his experience has been with this.
So thanks, David. First of all, as far as the Eggers procedure, I think that that's going to have a role, but in selected cases. And I think the things that David was talking about are really some very good guidelines for what to do, when to do soft tissue, get the foot aligned. For lever arm, have the foot in front of the knee, and avoid a fixed deformity. If you get a fixed deformity, the distal femoral extension. And then I think things such as hamstring transfer, and they come in, but I think they're going to have a very selected role. So yeah, I also think it's very important to retension the patellar tendon. I tend to take it off the distal pole of the patella, cut about 1 centimeter, and then reimplant it into the patella. I don't have to go down towards the tibia. I don't have to take the tendon off there. But it doesn't, if you just fold the tendon, they tend to stretch out. But the point is, the main point is that when you extend the distal femur, you have to tension that again because you've changed that relationship. And patella alta occurs anyway with crouch gait. So one of the more powerful parts after you get them straight is bringing that patella down, and that'll help maintain that. So I think making sure you're thinking of all the mechanics and the follow-on procedures and what you're going to create is very important.
Thank you, Dr. Scott. Thank you. We have one or two questions to Professor Dalal, if she is still with us. Professor Dalal?
Yes, I'm here.
Fine. People asking, you start the bisphosphonates before doing any surgery.
Yes.
And
So-
is it a maintenance treatment? Is it a maintenance medical treatment or just
So
for
we
a
start
certain-
with the pomidronate as soon as we see the patients. It helps
Yes.
strengthen the bone and the muscles. So once the bone is strong enough, and once the medulla is wide enough, then we
for how long do you think? How long
2
it
years,
would be?
minimum of 2 years, 8 doses.
2 years. So you don't do any surgery, even if there's
No.
deformities there, until you
Yes.
strengthen the bone and the muscles, yes?
Yes. So
Uh-huh.
after that, we do the osteotomies to correct. And once we have the bones and everything straight, we go back. Once we have the osteotomies healed, we go back on track for the pomidronate. We usually try to use the IV medication as much as possible till skeletal maturity. Then we transfer to the oral.
Uh-huh. Is there any adverse effects, or this is a type of critical treatment, isn't it? Is there any adverse effects you met with this?
Well,
treatment?
hypocalcemia has been seen during infusion. That's why the patients need to be on calcium and vitamin D orally. On the long term, we haven't found any problem from the medication rather from the disease itself.
And is there evidence that this decreases the chances of refracturing?
Yes, yes. A lot of papers are there. A lot of
Yes,
papers.
yes,
Gloria
yes.
started it in 98. And a lot of papers came after that. The meta-analysis that I spoke about is one of the proof, even to improve function.
Yes. So it shows that it decreases the incidence of refractures in spite of trauma or trivial traumas.
Yes.
Yes.
And then when you have the intramedullary nail, it acts as internal splinting. So you have less casting to use. So even if they fracture with the nail in, you don't need to cast them for a long time.
Yeah. Yes. And we actually treat a few of these cases, or many of them, with the plate and screws. We don't have the nails. So and we don't think it's very bad. It's okay. I mean, the screws can fit good, and the plates is still there. So
after they grow, does not go out of the bone?
No.
They don't fracture above or below the plate?
In the diaphysis, if they have a trauma, a new trauma, they might refracture, but for correction of established deformity, plates are still good. Don't you agree?
I don't, because what I see is they break above or below the plate, and then you create another cora, another deformity.
Yeah.
And then we have cases of cut through where we see the plate coming out of the bone completely after they grow a few years later.
I don't have any other of the Dr. Thamer, you.
Hey, well, I have the last remark, if you don't mind.
Yes, please.
Back again to our old friend, the Ceftriaxone. I want to raise a point, which is...
We're talking about plates with the Osteogenesis Imperfecta. With the Osteogenesis Imperfecta.
I have no good experience with treating surgical treatment for osteogenesis. So if you want me to...
They are not very common, but every orthopedic surgeon came across 1 or 2, 3 cases.
Yeah, I mean, I don't have a good voice in this matter.
Okay, thank you very much. Thank you, Dela.
Can I remark on Ceftriaxone?
You can.
Again.
Yeah, back again, I mean, it's a vital point that not all antibiotic can reach the disc, because we need to have a positively charged antibiotics. Antibiotics are 2 types. One is negatively charged, and the second is positively charged. So some of colleagues, they take a swab and they give antibiotic according to culture. For example, the ampicillin, the penicillin, the amoxicillin, all these are useless. The concentration is 0. So it's a point to be considered is the whether the antibiotic is positively charged or negatively charged. And thank you very much.
So the disc is positive or negative?
You need a positively charged antibiotic, not like a negatively charged, like ampicillin and penicillin and others. You need the gentamicin, ceftriaxone, tobramycin, all these are effective. But many antibiotics are useless. If you give it to disc space infection, the concentration is 0.
Thank you. Dr. Walid, can you hear me? One of the colleagues suggested radio frequency for this parabolation of this cysts.
Yes. You hear me? Sorry.
And maybe it's not available with us, but it's mentioned. Yes.
Sorry.
Have you thought of that?
You hear me? You hear me?
I can't hear you. I'm sorry.
We can hear you, Ustad Walid. We can hear you.
Okay, thank you. I think it is not written, not indicated for the cases of osteoblastoma. Radio frequency ablation.
Can you hear him? Can you hear Walid?
Yes, we can hear him, Dr. Muhammad. We can hear him.
Sorry, radio frequency treatment or therapy is, I think, applied only for the osteoid osteoma rather than osteoblastoma.
Well, no.
But of course, we have no experience with this subject, really. But this is in the literature, in the books.
Thank you very much. Thank you.
Thank you.
If you allow me, we have few cases of osteoid osteoma and non-ossifying fibroma, but it hasn't been used in osteoblastoma as far as I know.
Yeah.
Radio frequency ablation.
Yes, thank you, Dalal.
Dr. Ali Al-Hilli, you've raised Ali. Yes, you have raised an interesting points, and it's all concerned about teaching and learning of the orthopedic surgeons actually, and obviously those points you mentioned are supposed to be basics in the learning, because you cannot by giving a board certificate you cannot produce a full orthopedic surgeon, but at least a safe orthopedic surgeons. And we expect them to know the key points of treatment that if they ignore it would go worse. We don't want them to ignore condition that might go worse. If they delay an elective case, no much harm will be done. But if they delay a septic hip or a septic joint, of course this will give harm. But the family role, if the family refuse surgery, what would you do? You need to go on alternative. Some families they don't want to have surgery, and so you are obliged to explain to them the condition, the possibilities of the complications, and then they will take their chances, because the child have nothing to say about himself. What do you think?
Yes, sir. Of course. Yeah. You know what? How we can overcome the family if we are pediatric orthopedic surgeons, and we have one speech and one rules. So slipped capital femoral epiphysis, unstable, needs to be treated by surgery. So he don't find any. Yes, sir. If he don't find any other surgeon who told him no, you don't need surgery. So we need to educate ourselves more.
This is mistake, of course.
Yes, sir, definitely. But we have more. The family is the most difficult part of the equation. But if we have one speech and one rule, we can convince them by the treatment. At the end of the road, they would like to have the best health care for their children. So just we spend time with them, speak with them, telling them the truth, and then they would accept this. But first, we need to be a true pediatric orthopedics by ourselves. And I think this is the key. Thank you, sir.
Sure, of course. So subspecialty or concentrating on one subject, it's always better to produce a better opinion
So
and to deepen
if you would allow me,
experience.
can I comment
yes,
also?
yes, Dalal. Yes, please.
يعطيكم العافية. I know
you are in teaching and you're in this subject. Yes, please.
It is difficult to, the families are a bit difficult. They're the worst part of the equation. But like what Dr. Ali said, so we in Saudi Arabia, we're trying to make that voice. So just not only having a pediatric orthopedic fellowship, but being part of the Saudi Orthopedic Association, we have a pediatric chapter that is responsible to unify as much as possible, like what the POSNA is doing, like Pediatric Orthopedic North America. So we are trying to unify how DDH is being treated. We are trying to unify what we are doing for the sickle cell patients. We are trying to unify the common practice, having a full protocol where it is already written and it is there in the website even. If the parents want an education in Arabic, it is there in the website where we can explain DDH should be treated as soon as possible. You should pick up those patients, the high risk, a breech presentation, positive family history. So if you have that in Arabic and it is in your website as a Iraqi association, it makes it a stronger voice for education of both the patients and the parents and the doctors. That's my suggestion.
Thank you. So you're setting guidelines. Setting guidelines
and putting educational material in your website for the patients, which makes it more authentic.
Yes.
They would believe it more.
Guidelines for the doctors and centers and instructions and directions for the families to read in their language, in their home language. Yes. Dr. Hassan, you wanted to add? Yes, please. Yes, go ahead.
I just want to comment on Dr. Ali talk. It was a very, very important subject, and we've been suffering from this business since the last 50 years. So the point is, I mean, to say it is whom to blame, to me is all of them to be blamed except the child himself. The other thing, to have a specialty in pediatric surgery, this is very, very important, but because this is our era, at least we have to specify pediatric surgery as a separate from the other parts. But I am not in the era to more than fragment the pediatric surgery itself, because our orthopedic surgery, it is already fragmented. One say I only do the knee, one say I only do the elbow. But regarding our era, no, it is pediatric surgery, okay. But I don't like to say we are in an era, I only work with the pediatric surgery, just the hip, just the clubfoot, just the polio, just this CP. This is not our era, because just now, even in the Britain, they forget about the business. I mean, to do too much subspecialty. The radiologists say, only do MRI, only I do CT, only I do plain X-ray, only I do skeletal pediatric. I only afraid to reach this stage because it is too early to us. Thank you.
Yes, if you have too many people to do this, you can divide them. It's all right, but we don't have enough number of radiologists or surgeons to divide them into specialties. This
give it Ahmed in Arabic. ما كل ما يتمنى المرء يدركه تجري الرياح بما لا تشتهي السفن. كذلك عرفت القصة.
Thank you.
أستاذ محمد.
Yes, Wali.
Simple comment. With most respect to all orthopedic surgeons, we are used to go to attend the POSNA meeting annually. 3 years ago, the pioneers of the pediatric orthopedic from the whole world, they had a panel discussion. In conclusion, they said the best and the most moral and ethically well surgeons are the pediatric orthopedic surgeons.
They said that.
Yes.
Of course they said that.
هذا مو تحيز بس they said that the most beloved surgeons are the pediatric orthopedic surgeons.
They are pediatric orthopedic surgeons.
The second thing, I think David can help me. They have a fellowship of pediatric orthopedic. They have 2 fellowships. So it is divided into 2 branches. 2 fellowships for pediatric orthopedic. Ustad Hassan.
Why 2?
I think it's just something general, something related to the foot or the spine is separate.
Yes, maybe.
So 2 fellowships in pediatric orthopedic, right, Dr. David? Or
I think, and Scott can chime in, I think things have definitely evolved in the 22 years since I did my fellowship. And yes, it's true, and that, you know, if you think about it, the number of pediatric orthopedists in the United States have tripled or doubled at least since I became a member of the POSNA in 2001. So we have so many practitioners and so many of the problems are being diagnosed and solved earlier. For example, DDH diagnosis. So you have so many practitioners and, you know, for example, with DDH, many graduates in the United States aren't even competent in doing open reductions for hips because they haven't had sufficient clinical experience. So my perception is that with great numbers, that people are starting to super specialize in order to keep relevant and keep busy. It's a marketing advantage. So nowadays, I can understand it for tumors, for example, because in order to practice tumors and be credentialed at hospitals and join the tumor society, you have to have had a fellowship in tumors. So people will do peds and tumor. But for sports medicine, for example, to me, it's just more of a marketing advantage. So, and there's also the hip stuff, which is most of us were not trained in an era where we learned surgical dislocation of the hip and Gons osteotomies. So nowadays, people are choosing to do a second hip fellowship. So it's getting super specialized. And I feel, I don't know, Scott, I'm waiting for his opinion, but I almost feel like I'm a dinosaur at 57 years old because I'm still trying to do things in multiple areas. Next thing you know, there'll be a great toe surgeon.
Yes. Dr. Mohammed?
Yes, Scott, you want to add?
Sorry.
I was just going to say that I think that, at least I think Ali Bakr has identified, you've all identified a problem, which is elevating the standard of knowledge of pediatric orthopedics. And one route is a fellowship, and naturally I like that idea because David and I are both fellowship trained. But I think if the, you know, many ways to do it, if a group of orthopedists interested in pediatrics came out with some standards that was endorsed by the Iraqi Orthopedic Association, then other orthopedists would see slipped epiphysis. Oh, we're no longer waiting on those. So I think Ali Bakr's identified with his cases, and many of you have seen, that there's an opportunity to elevate the standard level of knowledge of pediatric orthopedics across many areas of Iraq. And there's a lot of different ways to do that, but at least we can see that there's a goal.
Yes, thank you very much. Of course, this is the goal of everybody.
Yeah.
This is the goal of everybody. Yes, Walid. Sorry, Scott.
تعقيبا على أستاذ حسن, I comment with أستاذ حسن for the subspecialties. ماضي أستاذ ثامر ويانا أو ما موجود أستاذ ثامر؟ أستاذ ثامر, إحنا we've been at the AAOS meeting in San Diego 2011. And the opening ceremony was in the subspecialty for how level we are going to go for subspecialties. This is the beginning of the meeting. And all of them, they agreed that this is not good, complaining of this. And if we need somebody to work, he said, no, I am only I specialize in thumb surgery, only thumb surgery, or only this surgery. So nobody can fix the radius. Nobody can fix the tibia. And they are totally against this subspecialty, Sir Hassan. Thank you.
I agree, Walid. And this is which is written by Cimento in his last book, Orthopedic Surgery Needs Balance. he also complaining of this business. I mean, sub-specialty. As you said, don't say, I only work on the thumb. And there is a book, textbook. It is surgery of the thumb. Surgery.
Of 2 volumes. Of 2 volumes.
2 volumes.
Yeah.
Shukran.
Shukran.
Could I make one more comment? Would that be okay?
Yes, okay.
One thing I have seen, because as many of you know, my wife is from Pakistan, and I've been very active in doing trauma courses and visiting there regularly.
Yeah.
So about 3 years ago, they started having fellowships, pediatric fellowships, and the National Orthopedic Organization has bought into that. And so now there are 30 or 40 pediatric orthopedists or people who are focusing on that. So that's been very well received thus far. There are only 2 centers that have been established to give that training, and meticulous curriculum has been developed.
Yeah.
But what I mean to say is the point I'm trying to make is that now this group of individuals who are very interested in pediatric orthopedics are developing, for example, I'm active in a trauma course that we've been giving in different regions of Pakistan 2 or 3 times per year. But in other words, the small group interested in pediatrics have not only been training a small number of fellows, 2 per year, or maybe it's 4 per year now, but what they've been doing is, under the guidance of the parent association, the Pakistan Orthopedic Association, they've developed teaching initiatives to try and address the issues that are of value to the general orthopedic surgeon in Pakistan. So in particular, trauma has been one issue. And so DDH and clubfoot are now coming. So they've actually served the parent institution as an educational resource. And I think that's been of value.
Thank you very much. Thank you very much. I have a comment from Dr. Burair. Burair are with us. Thank you very much. Yesterday, you spoke a lot about the screening for the DH, and that was very interesting. And I had a comment from another province in Iraq, apart from Karbala, and they said they were started another program, and they are happy with it and it's successful. And we congratulate them on that as well. So it's now more than one place that are starting a pilot program for screening for DDH. That's in Najaf, Dr. Walid. Walid, you are with me? That's it's in Najaf province. Another group of people who
Dr. Adnan and Dr. Alwash.
Ahmed Alwash and Adnan Kilabi also starting a screening program for DDH and going parallel with the club and the clubfoot as well. For
Paul Ziti,
so this is an interest in pediatrics as well. So
very good.
Educating everybody, not necessarily subspecialty, but educating even the general orthopedic surgeon into the pediatric aspects of certain problems that are common in the society to avoid going into mismanagement, as we noticed from Ali's talk, or delayed in treatment and so on. So this is good, and we are happy to hear that there are too many people are interested to distribute this education and trying to get this experiment to successful until we can convince probably the ministry to make it as on a national base. Maybe a few years later, it could be on a national base. Thank you very much.
Thank you.
Any comments from any of the, I think everybody's tired now, or anybody want to add any comment before we say goodbye? Or yes, Ali Halit, yes, please.
Thank you, sir.
Yes.
Thank you, sir. It was a great honor to be part of this great event. My idea 20 years ago, orthopedic surgery is totally different. Today, it's different. 20 years in the future, it would be different. It's orthopedic surgery is a rapidly growing specialty. And today, we need to be convinced about subspecialty. Maybe within 10, 15 years more, we go for super specialty. But if you ask me, if I have a baby with a clubfoot, where can I take him? Definitely for a person who is doing a clubfoot in the perfect way. Not a person can doing femur, radius, ulna, tumors, clubfoot, osteogenesis, CPs, So this is my idea. I respect all the opinions, but it's a point of view. Thank you for your time,
yes,
sir.
of course. Thank you very much. Thank you very much. Yes, yes. This is the question of a general. You know, now should not forget that the general practitioner or the family doctor is probably in focus now in the world, because this is the first line that he should diagnose the condition and direct it into the correct direction to the pediatric surgeon, pediatric orthopedic surgeon, or adult or hip or else. So the base knowledge should be to everybody, and the techniques, because of the techniques and the appliances that are evolved every day or every year, these subspecialties or dealing with the techniques is a need. Yes, I agree with you. Yes. Any comments from any of the distinguished speakers, please? I think everybody is tired.
Thank everyone.
Thank you very much. I took this opportunity to thank all the speakers, our dear guests, for this supporting this meeting of the Iraqi Orthopedic Association, and a special thanks to our people in Basra because they organized this, and a special thanks to Asino Scientific Bureau to help to organize and support this meeting. Special thanks to our guests from the United States, David Spiegel and Scott Hoffinger and Professor Dalal from the Saudi Arabia, and of course we are Iraqis. We all, this is not very much. Thank you very much all. Ali Mohsin, you want to add anything, please, before Ali?
Yes, I would like again to thank our esteemed speakers for their time, dedication, and their efforts. Actually, it was a very fruitful webinar, and we hope to make it again and again in the future. The thanks are also expanded to all of the audience who participated yesterday and today. And I have told you we had never have that large number of attendees in one webinar organized by Asino. So this is another success added to the webinar. Thank you very much, and we hope to meet you again in the future, in the near future.
Thank you all.
Thank you all. Thank you all.
Thank you all.
Thank you. See you in another opportunity. Bye bye. Bye bye. Bye bye. Good night.
مع السلامة يعطيكم العافية.
مع السلامة دلال. مع
السلامة.
مع السلامة. David Scott. Goodbye. Goodbye.
We'll see you soon.
See you soon. Hope to see you soon. In Baghdad.
Thank you so much.
Thank you.
Bye.
Thank you. Bye. Bye.